Hello, my name is Ariana Mills. Last summer, I worked in Mount Sinai Hospital with my mentor, Dr. Joanne Stone, researching whether preeclamptic women carrying twins are at a higher risk for maternal and perinatal morbidity than preeclamptic women carrying singletons. Preeclampsia is a unique illness that affects women during pregnancy. It is characterized by high blood pressure associated with protein in the urine. Preeclampsia may be characterized as mild or severe, as you can see here, depending on the patient's blood pressure and their amount of proteinuria. This may lead to poor urine output, visual disturbances, abnormal liver function, fetal growth restriction, and seizures if preeclampsia elevates to eclampsia. Preeclampsia is the leading cause of fetal and maternal morbidity and mortality in the world. Unfortunately, the underlying cause of preeclampsia is unknown. There are also no tests to predict who will get preeclampsia. However, physicians are aware of factors that increase one's chances of developing the illness. In our research, we focused on the risk factor of twin pregnancy. Our research also focused on the ways to manage patients with preeclampsia rather than the cause of the illness. As of now, the only known treatment for preeclampsia is delivery. Listed on the slide is the typical management for preeclamptic women with a singleton or a single child. For healthy pregnancies, delivery is usually around 40 weeks or 9 months. Depending on when a woman is diagnosed with preeclampsia and the severity of her illness, as you can see listed over here, physicians must decide when to deliver her baby. This is a difficult task considering the risk of preeclampsia and that preterm delivery is also a leading contributor to illness in children. In addition, it is not known whether twin preeclamptic pregnancies should be managed differently than those of singletons. Here's what we do know about twins. They usually deliver earlier than singletons, and they have an increased risk of complications due to preterm delivery. Our research was focused around answering these questions. Are preeclamptic patients carrying twins delivered earlier than their singleton counterparts with comparable disease severity? And are preeclamptic women with twins at a higher risk for adverse outcomes than women with preeclampsia carrying singletons? We used an electronic database to identify patients with preeclampsia and reviewed each chart separately to confirm their diagnosis and extract data. We classified the women into 3 groups. These 3 groups, depending on their gestational age, listed here, and the severity of their preeclampsia. We found that for all 3 groups, women carrying twins were more likely to be married, non-Black or Latino, and have private insurance. In both of the severe preeclamptic groups, women with twins were older and had less chronic hypertension. Our results were that there was no difference in gestational age at delivery of twin and singleton pregnancies with preeclampsia under 34 weeks. For women with mild and severe preeclampsia above 34 weeks, twins were delivered at a significantly earlier gestational age. No differences in markers of morbidity in twin versus singleton pregnancies above 34 weeks were found. And most interestingly, among severe preeclamptics below 34 weeks, singletons had evidence of more severe disease, which is displayed in this table. The red rows indicate the values that are most statistically significant. Singletons had evidence of more severe disease in that they had higher blood pressures, they had more need for antihypertension or high blood pressure medication, and they had a higher need for C-sections due to non-reassuring fetal heart rate status. Women with severe preeclampsia below 34 weeks carrying singletons had a greater disease severity than their twin counterparts, which physicians should be aware of and watch these patients closely. But although preeclamptic women with twins above 34 weeks had similar disease severity compared to singletons, they were delivered significantly earlier. This raises the questions of whether it was due to a physician bias or whether the preeclamptic women naturally gave birth earlier on. But based on our findings, twins whose mothers are preeclamptic with a gestational age above 34 weeks can be managed similarly to singletons. Thank you to Dr. Stone, my mentor, her daughter, Chloe Gatrajman, who I also worked with, and Dr. Bloom and Dr. Cox for helping with the science symposium.